So good evening, everyone. Am I audible?
Yes.
Good evening, everyone. I'm Dr. Neha Deshmukh from the medical team of AstraZeneca, and I welcome you all to our scientific session focused on the management of HER2-positive gynecologic cancers. Today's session brings together leading medical experts to discuss the latest breakthroughs and future directions in this dynamic field. We'll just see today's agenda. The key highlight will be a talk by Dr. Anna Oaknin, followed by a session on diagnostic by Dr. Sangeeta ma'am. And then there'll be two case-based panel discussion, one on ovarian cancer and the other on endometrial cancer. So I'm pleased to introduce our program director, Dr. Shona Nag, a leading medical oncologist with expertise in breast and gynecologic cancers. As a director of oncology at Sahyadri Group of Hospitals, Pune, Dr. Shona ma'am is renowned for her clinical excellence, research contributions, and commitment to cancer education. May I request Dr. Shona ma'am to set the context for today's meeting and also to introduce our international speaker.
Ma'am, you are on mute.
Hello.
So good evening, everyone, and welcome to this very exciting webinar on HER2-positive gynec cancers. I never thought the day would come when we'd be discussing treating HER2-positive, not only endometrial, but ovarian and cervical cancer as well. And it gives me great pleasure to introduce our chief speaker for today, Dr. Anna Oaknin. He is the head of the Gynaec Cancer Program at the Vall d'Hebron Institute of Oncology in Barcelona. He is a prominent international leader in gynae oncology. Professor Oaknin plays an active role on the ESMO Gynaec track as faculty. He has served as an ESMO committee member for several meetings. He has also contributed as editor for Gynaec Malignancy Guidelines and currently chairs the Gynae Cancer Congress. She's been the past chair of Gynae Cancer Intergroup Cervical Cancer Committee and is also an active member of ASCO. She got her medical degree from Madrid and is a PhD cum laude from Barcelona. Her main focus is on clinical research on multiple phase 1, 2, and 3 gynae cancers, and notably, I'm very, very apt for today, Professor Oaknin is the principal investigator and the author of the Destiny Pan-HER2 study. So over to Dr. Oaknin. I request her to begin her talk.
Thank you so much, Dr. Nag, for your kind introduction. I really appreciate all your words. And thank you, AstraZeneca, for inviting me to share this interesting webinar with you all. As you have said at the beginning, this is a rapidly evolving landscape, but very exciting at the same time in gynecological tumor. So let's review all together. I'm going to share my screen. I think you can see my screen right now.
Yes, ma'am.
Yes, ma'am.
Okay, perfect. So, the focus of my talk will be redefining treatment pathways in advanced endometrial cancer. So, this is my disclosures. We know that endometrial cancer is one of the most common gynecological tumors. Indeed, almost 400,000 women were diagnosed with endometrial cancer in 2022, and approximately 100,000 deaths were due to endometrial cancer. However, the key point is that endometrial cancer is the only gynecological malignancy for which the incidence is rising, and then we expect a higher number of cases by 2015. We know that endometrial cancer, when it's diagnosed at early stage, it can be cured only with surgery or radiotherapy plus minus adjuvant therapy. However, when our patients are diagnosed in advanced stage, stage 4B, the prognosis is very poor. Until now, we can state that the 5-year overall survival for those patients was around 70%, and due to the high rate of recurrence for this stage. And what happened with this patient? The big problem was that we had at that stage limited treatment option for our patients with advanced or recurring endometrial cancer. I have tried to summarize in this table the different chemotherapy regimen that we have studied across the last 20 years. And then I will be focused on the GOG 177, where we analyze the combination of doxorubicin, cisplatin, and taxane. And this combination was superior to the standard of therapy at that stage. We are talking about 2003, that were doxorubicin plus cisplatin. So the next step was to compare the triple regimen with the most common regimen used in gynecological cancer, that was carboplatin plus paclitaxel. So this comparison was carried out in the GOG 209. As you know, this trial has established the current, I would say now not current, but what has been the current standard of care for a long time, that was paclitaxel carboplatin. In this study was a non-inferiority study. We compared the triple regimen with the carbotaxol. We enroll patients with stage 3 or 4 or recurrent, and those patients must have not received prior systemic therapy. And you can see in the slide there's no difference between both regimens. However, the tolerance for paclitaxel carboplatin was much better. Let me bring your attention to the median PFS. It was around 30 months, we can say 1 year, and then the overall survival was around 2 years, a little bit more. So there's room to improve our outcome. And what was the problem that we have been facing for a long time? The problem was that we consider endometrial cancer almost the same disease. We try, to split endometrial cancer in two categories, type 1 and type 2. And this differentiation was mainly based on histopathological feature. You know very well, type 1, were those low grade, estrogen dependent, and type 2, high grade, serous carcinoma, estrogen independent. But we learned that this classification was very poor and was not able to identify the best therapy for each patient. So the turning point in the endometrial cancer was brought to the table by the TCGA classification. As you know, TCGA segregates endometrial cancer in 4 different molecular subgroups based on genomic abnormality. The TCGA identify poly group, MSI high or hypermutated group, copy number low, and copy number high. And while this classification was very prognostic and very useful, it requires complex methodology. So this classification was replaced by a more, I would say, a more simple classification that can be can be established in our daily practice. With this classification, then we identify 4 molecular subgroups as well: polymutant, mismatch repair deficiency, NSMP, and P53 abnormal. And let me tell you something, these 4 subgroups were analogous but not identical to the TCGA. However, we can state that the molecular classification was a prognostic classification. And we can see here in the Kaplan-Meier curves, those patients with polymutant, they have an excellent prognosis. Patient with P53 abnormal or P53 mutant, they have the worst prognosis. And then we have a 2 group with an intermediate prognosis where the NSMP or mismatch repair deficiency. But this classification was not only prognostic, but predictive of response to therapy. And you recall in the PORTEC-3 trial, that was an adjuvant trial, we can see how the recurrence-free survival for those patients were different according to the molecular subgroup. And once again, we confirm that the best prognosis was for polymuta and the worst prognosis was for those patients with p53 abnormal. With all this knowledge, we decided to incorporate the endometrial molecular classification into our clinical guideline, not only to determine this subgroup, but to guide our therapy, to try to have a personalized therapy according to this molecular classification. This was in 2022, and now recently, almost 1 month ago, the new classification, the FIGO 2023, has been incorporated in the new ESGO-ESTRO guidelines that I have tried to summarize in this schema. As you see, having the molecular data for all endometrial cancer are mandatory in order to establish the subgroup. Then we identify once again the poly, mismatch repair deficiency, NSMP, and what is new for the NSMP is that we have split this group according to the status of estrogen and progesterone receptors, considering that those patients with ER or PR negative, they have a poorer prognosis compared with those who are positive. And finally, the p53 are normal. So among all these molecular subgroup, I will start focusing on the dMMR. dMMR in endometrial cancer are approximately 25-30%, and I must say that endometrial cancer is the solid tumor with the highest incidence of the dMMR tumor. And why this fact is so important? Because in a very brief manner, I will say that the dMMR tumor are associated with a high rate of mutation, so they express a high level of neoantigens, as you can see in the left on the cartoon. As a result of this high expression, there's increase in the tumor cell, in the T cell infiltration, and an expression of the checkpoint in the tumor cells as PD-1 and PD-L1. So all this microenvironment makes endometrial cancer as the ideal candidate to develop immunotherapeutic intervention. What have we learned from immunocheckpoint inhibitor endometrial cancer? If we go back at the beginning of the clinical development, for those patients who had already received platinum therapy and they have recurrence, in those whose tumor are dMMR, the overall response rate for immunotherapy as monotherapy was quite high, from 50% for pembrolizumab, 45% dostarlimab, and 47% for durvalumab. However, what happened when we look at the pMMR subgroup of patients? In those patients, immunotherapy as monotherapy didn't show compelling activity. So these agents were combined with anti-angiogenic, as was the regimen pembro-lemba, and they show an overall response rate 30%. So in the pMMR subgroup, it seems that we need something else that's only checkpoint inhibitor. So, but the fact is that we have seen a great activity of the immunocheckpoint inhibitor after platinum failure. So the next step, or the next logical step, was to incorporate immunocheckpoint inhibitor in the first line therapy, combining only with chemotherapy or also with PAR inhibitor. And what is the rationale behind this combination? The rationale is that both chemotherapy and PAR inhibitor increase the immunogenicity of the tumor. So it can have a synergistic effect with immunocheckpoint inhibitors. So the next question that we should make ourselves is, would the addition of anti-PD-1, anti-PD-L1 antibody plus minus PAR inhibitor to first-line platinum-based chemotherapy sufficiently effective to improve our outcome and to be incorporated as a new standard of care? So we have 4 important clinical trials, phase 3 clinical trials that have addressed this question. The Ruby trial with dostarlimab, 018 with pembrolizumab, a 10 trial with atezolizumab, and the DuoE trial with durvalumab plus minus olaparib. And today we will be focused on the DuoE trial due to the recent approval that you have got in your country, in India, for this combination. So let's review deeper this trial. DuoE. The DuoE enrolled patients with newly diagnosed stage 3 or 4 endometrial cancer or in recurrent endometrial cancer. Patients must have been naive for systemic therapy for the recurrent setting, but the patient may have received chemotherapy as neoadjuvant or adjuvant setting as long as they have finished this chemotherapy at least 1 year after, 1 year after the diagnosis of the recurrence. I don't know if I explained well myself. So when the recurrence occurs, if the patient has received neoadjuvant or adjuvant chemotherapy, it should be at least 1 year ago. Now I think I explained better. And then all histologies were allowed except sarcoma. So more than 700 patients were enrolled and randomized. And then the patients were randomized in 3 treatment arms that I will explain slowly. The control arm was paclitaxel carboplatin, the standard of care. One experimental arm was paclitaxel carboplatin plus durvalumab, followed by durvalumab plus placebo. And the third experimental arm was carboplatin paclitaxel durvalumab, followed by durvalumab plus olaparib as maintenance therapy. What was the duration of maintenance part? The duration of maintenance part was until progression or unacceptable toxicity. Primary endpoint. The primary endpoint of the study was a dual primary endpoint. Each experimental arm was compared with the standard arm, namely chemo plus durva versus chemo, chemo plus durva followed by durva plus sola versus chemo. And something that I would like to stress, it was a predefined exploratory analysis to compare the 2 experimental arms in order to determine the contribution of olaparib. And the key secondary endpoint was overall survival. I think it's worth reviewing the statistical analysis in order to understand much better the outcome that I will be presenting later. The statistical analysis was to determine the PFS independently in each experimental arm compared to the control. And on top of that, the PFS analysis was an event-driven analysis. And remarkable, the interim analysis for overall survival was determined at the time of the PFS analysis. So let's review the patient baseline characteristics. Just point out a few of them. 20% of the patients had tumor DMMR or had DMMR tumor. First thing. Approximately 52% of the patients were enrolled with recurrent disease, and 20% of the patients have previously received chemotherapy. And something that is relevant for the duo E, and I think is a key difference with another phase 3 trial that we'll review later, is that in that study, approximately 30% of the patients were from Asia. And we know that this may have an impact on the outcome. So, and here the primary endpoint, PFS in intent to treat population. As you can see, the trial was positive. When we compare each experimental arm with the control, each one is positive. Durva versus control has a ratio of 0.71. It means a reduction of 29% in the risk of recurrence of death. Durva-Ola compared with control has a ratio 0.55, a reduction of 45% in the risk of recurrence of death, with the p-value highly positive, 0.001. Interestingly, when we look at the median PFS, for the control is 9.6, is what we have seen in the AGOG 209. For the Durva-Ola 10 months and the Durva-Ola 15.1. And then something interesting in the Kaplan-Meier curve. As you can see, during the first 6 months, there are an absolutely overlap among the three curves, but later on, there's a clear and sustained separation for the both experimental arms compared with the control. And can we explain this? I think there's two facts. One of them is we know that the immunotherapy, that Durva takes time to make the most efficacy effect, and later on, olaparib was only given during the maintenance phase. If we move forward in the study analysis, we have this pre-specified exploratory subgroup according to the mismatch repair status. We have the dMMR and pMMR. When we look at the dMMR population, both experimental arms were superior to the control, with a hazard ratio 0.42 and hazard ratio 0.41 respectively. However, while the two experimental arms are superior, it doesn't seem that the addition of olaparib adds any extra benefit to durvalumab by itself. And now let's look at the pMMR. In the pMMR, the combination of durva-olaparib is clearly superior to control, with a hazard ratio of 0.57. and the median PFS of 15 months compared with 9.7. And more interesting, when we look at the percentage of patients who are free of progression and 1 year and a half, 18 months, twice as many are free of progression in the Durva-Ola compared with control, 42% versus 20%. So it's clear that the Durva-Ola in the pMMR population is superior to the control arm. Moving to the secondary endpoint, overall survival, I must say that these data are immature, only 27% of maturity. However, we see a positive trends in the experimental arms compared with control. When we look at this secondary endpoint according to the mismatch status, there's a clear benefit in overall survival in the dMMR, and also there's a positive trend in the pMMR in the combination of durvalumab plus olaparib with a hazard ratio 0.69. So, what else we can learn from here? When we look at in the pMMR subpopulation, the overall response rate and duration of response, and when you look at only the overall response rate, you can say, okay, there doesn't seem to to be many differences in the overall response rate, partial response, and complete response, although the complete response are double for the combination of Durva and Ola. However, when we look at the duration of response, here there's a clinically meaningful difference because the median duration of response is 80.7 months for the combination of Durva Ola, compared with only 7.6 from the standard and 10.6 only for Durva. Just refresh your mind that we are talking about PMMR subpopulation, the population where the regimen of Durva Ola has been approved. Safety. At the beginning of the trial, there was a lot of concern about the safety, but if we will review in depth this data, honestly, there's nothing new on the horizon. I think it's important to stress that the rate of discontinuation of the Durva Ola in the maintenance phase was only 40%. What was the rate of discontinuation of olaparib of another PAR inhibitor in ovarian cancer? Almost the same, between 11 and 50%. So nothing new in terms of safety. And according, to this table, you can see that the most frequent adverse events were neutropenia, anemia, grade 3 or greater, and there's almost the same in the 3 arm, a little bit more, but not significant in the combination of Durva Ola. But we know that anemia is one of the typical side effects that we observe with olaparib. But honestly, all of us now we are used to managing this side effect. So we have reviewed the DUOE. Later on, I can respond the doubt that you may have. But we said at the beginning that there's other three important clinical trials that have addressed the role of immunotherapy in first line. And as you can see, all of them have a very similar design, a standard arm, paclitaxel carboplatin, compared with chemotherapy adding immunocheckpoint inhibitors. So before jumping into the outcome, just a small note that for the sake of time, I have put together primary and exploratory endpoint in a few slides. So if we start looking at the DMMR and the impact on PFS, acknowledging the limitation of the cross-trial comparison, we can say that the magnitude of benefit in all the trials is almost the same, with a hazard ratio that range from 0.28 for Ruby Par 1 to 0.42 for the DUO-E arm 2. And when you look at the shape of the Kaplan-Meier curves are almost the same. Interestingly, in all the trials, there's a 20-25% of the patients who progress during the chemotherapy phase. These are the group of patients for which we should study further why having a DMMR biomarker, they are not able to respond to immunotherapy. In terms of overall survival, I must say that the only trial that has reported final overall survival is the Ruby one, with a positive impact in overall survival. However, the other three trials, as you can see, also show a positive tendency in terms of overall survival. Let's move to the PMMR subgroup. In the PMMR subgroup, when we are talking only the immunocheckpoint inhibitor in combination with chemo, the magnitude of the benefit, as you see, is less compared with the DMMR, but still for the 018 DUO-E and Ruby Par 1 positive outcome, the only trial that has been negative is with atezolizumab. However, the hazard ratio is around 0.67. And when we look at the data that have been presented in the PMMR, and then we analyze the outcome in this group of patients when we have the durvalumab immunocheckpoint inhibitor plus olaparib, the hazard ratio is 0.57. And when we look at the Ruby part dot that also analyzed the incorporation of PAR inhibitor, in this case niraparib in combination with dostarlimab, the hazard ratio was 0.63. So, I mean, once again, acknowledging the limitation, the cross-trial comparison, it seems that the addition of PAR inhibitor play an important role in combination with immunocheckpoint inhibitor in this subgroup of patients with endometrial cancer. And what is the key question? The key question is, what are those mismatch repair proficiency patients who benefit the most? Interestingly, in the duo E, the investigator carried out a very, very, useful analysis that it was a biomarker analysis. This biomarker analysis was able to carry out in 85% of the pMMR subpopulation. So when we analyze, deeper, the first point is that we identify an heterogeneous population. As you can see in the cartoon, with an overlap between the biomarker. Interestingly, 84% of the patients were positive for one or more biomarkers. And moreover, the most frequent positive biomarker were PD-L1 in 67% of the patients and mutation in P53 in around 59%. And when we look at the forest plots, as you can see, all the subgroup according to the biomarker status are moving in favor of combination of chemotherapy plus durvalumab olaparib. And when we look at the patient whose tumor are P53 mutant, the hazard ratio is 0.47, and this indicates that perhaps this is the group that has the most benefit from the addition of olaparib. On top of that, those patients with serous histology with a hazard ratio 0.47, but interestingly, also those patients with endometrioid histology. So in terms of PD-L1 status, as you can see, there's a huge difference in terms of benefit for patients whose tumor are PD-L1 positive according to the TAP assay. So if we put all this data together, we have ended up having these new guidelines that I will take you over this guideline. First thing, we should split the tumors according to the mismatch repair status. For those with mismatch repair deficiency, we know that the indication level of evidence 1 grade or recommendation A is chemotherapy in combination with immunocheckpoint inhibitor followed by immunocheckpoint inhibitor, either dostarlimab, durvalumab, or pembrolizumab. For those patients who are non-dMMR, chemotherapy should be combined either with immunocheckpoint by itself or immunocheckpoint inhibitor plus PAR inhibitor. In this case, only will be durvalumab plus olaparib. Level of evidence 1, grade or recommendation B. So, what happens when our patients have progressed and they have already received immunocheckpoint inhibitor as part of the first-line therapy? Here in the guideline for those patients who have received immunotherapy in the first line, our recommendation will be either single-agent chemotherapy or, interestingly, target agents against HER2. And why HER2? We know that when we look at the copy number high, there's a high expression of HER2 in this group of patients. And what do we know about HER2? In a very brief manner, we know that it's a transmembrane tyrosine kinase that mediates cell proliferation and apoptosis inhibition. A key point is that while breast and gastric cancer have very well established guidelines to determine the overexpression of HER2, In gynae tumor, we don't have this guideline. We are adopting, in the majority of studies that we review now, the gastric guideline. And according to that, what is the rate or what the incidence of HER2 overexpression 3+ in endometrial cancer? Around 6-70%, and 2+ around 30% and 40%. This depends on the series and the guideline that had been used to determine this overexpression. So I think, the first trial that showed the activity of anti-HER2 therapy in endometrial cancer, particularly in uterine serous carcinoma with overexpression of HER2, was the trial for Amanda Father, published later in the Clinical Cancer Research in 2020. As you can see, the addition of Herceptin to paclitaxel carboplatin show a benefit in terms of PFS and overall survival in those patients newly diagnosed with advanced uterine serous carcinoma. However, I must say that the revolution in the therapy of HER2 overexpression tumor has been driven by T-DXd, trastuzumab deruxtecan, that, as you know, is an ADC targeting HER2. The key characteristic is that the payload is a topo-1 inhibitor, that the drug-antibody ratio is 8, and the ADC has a cleavable linker. So we analyze the activity of T-DXd in the DESTINY-PanTumor02. DESTINY-PanTumor02 is a phase 2 open label where we enroll different solid tumors that overexpress HER2, but we will focus today in endometrial cancer. Importantly, patients were enrolled according to the HER2 expression determined by the local test. However, all patients' tumor were reviewed by the central test, and then when the central review was carried out, we used the ASCO guideline for gastric tumor. And then, we enrolled 40 patients in each cohort, and the primary endpoint was confirmed overall response rate. Since we enrolled the majority of patients with local tests, indeed 75% of the patients were enrolled with the local HER2 status, we established the correlation of the agreement, the percentage of patients that have the same overexpression according to the local and central. And look at the interesting result that we obtained. We observed that for the HER3 plus, only there was a 63% of agreement between local and central. And this agreement was even lower when we are talking about the 2+, was less than 50%. This is very important because if determination of the HER2 is not done properly, we are missing patients who may benefit of T-DXd as therapy. So when we look at the characteristic of patients in the endometrial cancer cohort, I must say that 80% of the patients have received at least 2 prior lines of therapy, that there are patients who have received previous anti-HER2 therapy, and most of the patients were 2+. Their tumors were 2+. And here the overall response rate. When we look at the whole cohort, the overall response rate was 57%. However, when we look at the 3+ determined centrally, it was 85%. Amazing overall response rate. 47% in 2+, and then you were wondering why you had 1+ and 0, because when we review centrally, many patients who were enrolled with 2+ or 3+, they were, reassigned to the 1+ or 0, and in those patients we also observe activity. And it's not only the high overall response rate, that the median duration of response has not yet been reached. In terms of different subgroup analysis and interest of time, just I will summarize, we have seen compelling overall response rate regardless of number of prior regimen of therapy, regardless of the patient have received prior HER2 therapy, and regardless the presence of PD-L1 positive or not tumors. In terms of median PFS and overall survival, as you can see, amazing median PFS in HER3+, because it had not yet been reached, and the overall survival, the median overall survival is 26 months for 3+, more than 2 years. So, safety, just as the latest part from the TDXD. Importantly, rate of discontinuation, very low, less than 6%. And when we look at the most common treatment emerging adverse event, as expected for the topo-1 inhibitor, GI toxicity, namely diarrhea, and hematological toxicity, anemia and neutropenia. And something that was a matter of concern at the beginning of TDXD development, ILD. When we look at the global rate of ILD, was 10%, any grade, and only one patient had a grade 5, no grade 3, and not grade 4. So this brings me to the end of my talk. We can say that treatment according to molecular profile is the way to move forward in advanced endometrial cancer and in the future in the adjuvant setting. Immunotherapy in combination with chemotherapy has improved both PFS and overall survival in the overall population, regardless of mismatch repair status. Platinum-based chemotherapy plus immunotherapy and plus PAR inhibitors could represent a treatment option for patients with pMMR patients, and predictive biomarker of response for sure are urgently needed to select our patient in the best ways. Thank you so much for your attention.
Thank you. Thank you very much, ma'am, for such a nice lecture. I could see few questions in the chat. If it is allowed, I would like to ask.
For sure.
So one of the question is, let's say if a patient is pMMR, PD-L1 negative by CPS, is immunotherapy gonna be beneficial? And the second situation is, if the patient is pMMR but strongly ER positive, is there a benefit of using immunotherapy?
Yeah, okay, we'll start with the first question. So according to the CPS, the CPS analysis was carried out in the 018 trial with pembrolizumab, and they show that all patients got benefit of immunotherapy regardless of CPS expression, namely less or greater than 1. In the DuoE, the assay that we have used is different, is TAP, is the tumor area positive, and the cutoff is less than 1% or greater than 1%. And it seems that the patients who are TAP positive, they got a greater benefit compared with those who are TAP negative. But I must say that when we are talking about the exploratory analysis, post-hoc exploratory analysis, I don't think that the treatment decision should be driven by this exploratory analysis. This exploratory analysis add, more knowledge, and somehow, they guide us in the future step in our clinical research. But I don't think that they should be the base to determine our therapeutic approaches.
Sure, ma'am. Thank you. Next question I could see. Suppose there is a patient who is pMMR. The patient also developed peripheral neuropathy due to paclitaxel in the adjuvant setting, and the disease-free interval is approximately 2 years. Now, the question is that can adriamycin be used with platinum immunotherapy along with olaparib?
Yeah, this is a very interesting question. The platinum-free interval in endometrial cancer has not never been studied properly. I mean, we are assuming the knowledge that we have in ovarian cancer. And then we are establishing, random cutoffs, either 6 months in the Ruby trial and 1 year, 12 months in the DuoE and the 018. The question that many physicians have is, should I retreat my patient with platinum-based chemotherapy after more than 12 months? Should I will be treated with platinum after less than 12 months? Should I will change my therapeutic approach if the patient had previously received paclitaxel carboplatin? My response is the following one. If the patient had received neoadjuvant or adjuvant therapy and at least 6 months have elapsed since the patient has finished the therapy until the recurrence appears, I should retreat my patient with IO plus paclitaxel carboplatin because it's the combination that had shown the best outcome so far. Doxorubicin, is an alternative option for those patients who have progressed after IO. But you keep in mind that the activity that doxorubicin has in the recurrent setting is an overall response rate of 16%, 1/6. And the safety profile is very poor safety profile. So honestly, for me, it will be the latest option that I will give to my patient.
Sure, ma'am. Thank you. Thank you for the answer. So, is immunotherapy effective in HER2 positive cancers and in which line?
I mean, now, it's very interesting. Thank you for all these questions. Now, as you know, we are going to launch, or we are about to launch, a phase 3 clinical trial in pMMR HER2 positive patient where we will compare TDXD with chemotherapy plus pembrolizumab. So, because we are trying to identify if this combination is, no, the way around. If TDXD is superior to chemotherapy plus IO in the HER2 overexpression tumor. Until now, we don't have this data, but we know that chemo plus IO is effective in patients with P53 mutant, and we know that those patients with P53 mutant, the majority of them are HER2 positive. And then we have seen that the IO plus chemo is also effective in serous tumor, as I show in the forest plot for the DuoE pMMR. So there's no data so far to infer that chemo plus IO will not be effective in those patients whose tumor are HER2 positive. The next step will be if the TSD is superior to chemo plus IO, but we don't know yet. We need to carry out the clinical trial.
Sure, ma'am. I could see one or two more questions. Any role of irinotecan in platinum refractory endometrial cancers?
Yeah, that question, arises due to the fact that the TDXD, the payload, is a topo 1 inhibitor, and irinotecan is a topo 1 inhibitor. So many physicians say, okay, if TSD is, very active in this population, why cannot irinotecan be used? Honestly, we don't have any data, any reliable data of the use of irinotecan in the recurrent endometrial cancer. So it's not considered a standard therapeutic option. So I don't think that we will be one of the therapeutic that should be put on the first on the list to treat our patient.
Sure, ma'am. So, ma'am, with this, I think to the audience, I would like to say that I could see a lot of questions, but I think that would be more applicable to the diagnostic session once Dr. Sangeeta will give her talk, and I can take up your questions again with her. So don't worry, because there are a lot of diagnostic questions as well.
Okay.
So once she will give the talk, I can take up your questions in the audience. Yeah.
Perfect. Wonderful.
Yeah,
Thank you.
Thank you, ma'am.
So, moving on to the next topic, Significance of HER2 testing, interpretation and reporting in gynecological tumors. It will be presented by Dr. Sangeeta Desai, former professor and head of pathology at Tata Memorial Hospital, Mumbai, and a renowned expert in clinical molecular diagnostics and digital pathology. May I invite Dr. Sangeeta ma'am to begin with her presentation.
Hi, good evening. Let me first share my presentation. Is the presentation seen? Okay. Yeah, so wish you all a very good evening. And right at the outset, let me thank Dr. Shona and AstraZeneca team for inviting me to this forum. And so the title of my talk is Significance of HER2 Testing, Interpretation and Reporting in Gynec Tumors. And so when we talk about activation of HER2, there are three major types of alterations. First is HER2 overexpression, where there is overabundance of HER2 protein receptor, and that is best detected by immunohistochemistry. The next is amplification. That means abnormally high number of HER2 gene copies, which is best detected by fluorescence in situ hybridization or next generation sequencing. And the third one is mutation, and that is best detected by next generation sequencing. And these alterations can result in hyperactivation of HER2 pathway, and that leads to oncogenesis through gene transcription and tumor survival, proliferation, invasion, and metastasis. So HER2 expression is frequent across multiple metastatic solid tumors, although we are used to or more tuned to interpreting HER2 in breast and gastric cancer. But if you see this long list of tumors, right from lung cancer, biliary tract, pancreas, and of course, gynecological malignancies like endometrium, ovary, and cervix. And if you see in the endometrium, the HER2 IHC3 plus prevalence is a little bit higher, almost 3 to 28%, and amplification is 4 to 8%. And the one important point to be noted is for certain tumors like lung cancer, is HER2 mutation that is more important, whereas in the rest of the tumors, it is protein expression or amplification that needs to be tested. My slides are, yeah. So NCCN recommends HER2 testing in multiple solid tumors. And so if you see the first column is lung cancer, and that I have already said is HER2 mutation. So advanced lung cancer where there is HER2 mutation, non-squamous lung cancers, and sometimes even for squamous cancer, TDXT and TDM1, they are recommended. And so all sky blue colored boxes are actually scenario where HER2 testing and treatment is recommended by NCCN. And if you come to gynec cancer, advanced recurrent ovarian and cervical cancer, again, TDXT is recommended for IHC3 plus or 2 plus tumors. For endometrium, it is all serous tumors and carcinosarcomas. And in fact, following P53 IHC, if there is abnormal cancer, regardless of histology, even those patients are eligible to receive carboplatin plus paclitaxel trastuzumab in HER2 positive, that is as the first line, or TDXT in HER2 positive tumors, IHC3 plus or 2 plus. And then there is a mention of colorectal, biliary. So point to be noted is now HER2 testing and treatment is to be offered in multiple solid tumors. And this brings me to Destiny Pan Tumor 02 trial. where HER2 overexpressed tumors, either IC3 plus or IC2 plus, were included, and the guidelines used were those which are used for gastric cancer, and the patients who were included, FFP samples were obtained at the time of diagnosis of metastasis or locally advanced unresectable tumors when patient presented. And tumor samples were not older than 3 years, and samples with limited tumor content, FNEC samples, were not included. And in this particular trial, HER2 IC status was assessed using HERCEP test, which is by DACO, and scored according to gastric scoring algorithm. And if you see, again, this is pan-tumor trial. So right from gynec cancers, bladder cancers, biliary tract, pancreas, all were included. And if you see the big box, it talks about efficacy of T-DXd across solid tumors, gynecological ones. So you concentrate on endometrial, cervical, and ovarian tumors. So if total patients are 267, IC3 plus were 75 and 2 plus were much more than IC3 plus. And if you see overall response rate, it is 61.3 as compared to 27.2 for IC2 plus, and for all patients it was 37.1, whereas median duration of response was almost 2 years for IC3 plus, and for all patients it was 11.3, for IC2 plus it was 9.8. So greatest benefit was observed for the IC3 plus population, and these data support the potential role of T-DXd, and it is tumor agnostic therapy for patients with HER2 expressing solid tumors. So now if you see the timeline of clinical trials and therapeutic approvals, the HER2 story started way back in 1998 with the FDA approval for trastuzumab for breast cancer, and then it continues with lapatinib and trastuzumab for gastric cancer in 2010, and then TDM1 for breast cancer in 2013, and then the story continues with T-DXd for approval for breast cancer in 2019, and T-DXd approval for gastric cancer in 2021. And 2022 is that beautiful moment which is described in oncology, when T-DXd was approved for HER2 low breast cancer, and in same year for HER2 mutant lung cancer also. And major trials mentioned here are in 2010, trastuzumab was introduced as single agent in endometrial cancer. In 2018, it was shown that trastuzumab improves PFS and OS in endometrial serous carcinoma. In 2019, NCCN endorsed trastuzumab for endometrial serous carcinoma, and then Society for Gynaecology recommended HER2 testing and trastuzumab for endometrial serous carcinoma in 2021. And then comes 2024 with T-DXd, FDA approved for HER2 3 plus. This is as per Destiny Pan Tumor 02 trial. So this is about unresectable metastatic HER2 positive IC3 plus solid tumors, and FDA grants accelerated approval to trastuzumab deruxtecan for HER2 positive solid tumors, and this happened on April 5th, 2024. Now, there are barriers identified in HER2 testing of solid tumors, and the major ones are although HER2 is expressed in multiple solid tumors, HER2 testing by IHC is not a routine practice, and we are more tuned to breast and gastric cancer interpretation. There are lack of validated HER2 assays and standardized HER2 scoring algorithms, which exist only for breast and gastric cancer, and that further confounds HER2 scoring. Now, coming to patterns of expression and tumor heterogeneity of HER2 in gynec cancers, if you compare the three cancers, ovarian, endometrial, and cervical, as far as heterogeneity is concerned, all three are heterogeneous, and heterogeneity is more pronounced in 50%, almost to the tune of 50% in endometrial cancer. The pattern of staining pattern is lateral or basolateral, and that's why gastric scoring algorithm is valid here. And major histologies with HER2 overexpression are mucinous carcinoma, mucinous borderline, clear cell carcinomas. And for endometrial, it is serous carcinoma, uterine carcinosarcoma, myoinvasive tumor foci or intravascular tumor emboli. And for cervix, is cervical squamous or non-squamous adenocarcinoma. So what is different in HER2 testing in breast cancer versus other tumor types in Destiny trials? If we classify the factors in pre-analytical, analytical, and interpretation, that is post-analytical, and if you follow the HER2 testing workflow, as far as pre-analytical factors go, or actual analysis, that is IHC procedure goes, there is no difference between breast cancer versus other cancers. However, if you see, if you notice that in breast cancers, that is breast cancer trial, that is Destiny breast cancer 04 and 06, 4B5 Ventana pathway antibody and Ventana platform was used, but however, for Destiny pan tumor 02 or lung cancer or CRC trial, Hercept test by DECO was used. And coming to the interpretation and scoring, for breast cancer trials, the actionable HER2 status was HER2 score 3 or ultra low or HER2 low tumors, whereas for in pan tumor Destiny trial, it was score 3+. And scoring guidelines for in breast trials were ASCO-CAP breast cancer breast biomarker guideline, whereas for pan tumor Destiny trial, it was gastric scoring algorithm. So as far as the testing procedure goes, IHC, ISH, and pre-analytical factors, there is no change. But what changes is the interpretation, scoring criteria, and the guidelines. So this is a summary of HER2 testing recommendation and the guidelines. And as I've been saying right from the beginning, we have well-defined guidelines for breast and gastric. So ASCO CAP for breast and ASCO ASCP CAP guideline for gastric. Coming to gynec cancers, for endometrium, it is federal trial scoring criteria, and ovary and cervix, there is no universal guideline. And for the rest of the tumors also, there are no guidelines available except for colorectal. Again, it is Heracles trial scoring criteria. Now, overall, for protein expression, it is immunohistochemistry, and for amplification, it is in situ hybridization. And in lung cancer, for mutation, it is genomic test at a next generation sequencing. So this is regarding the recommendations. So these are the two scoring, two guidelines, ASCO CAP and for breast cancer and for gastroesophageal cancer. So for HER2 testing in breast cancer, until say 2022, for the actionable status for HER2 was score 3. And now there is expanded positivity, expanded spectrum of positivity. And we are including also HER2 low as well as HER2 ultra low. So HER2 0 is now further split into null and non-null or ultra low tumors. And for gastric cancer specific HER2 scoring algorithm, this guideline is a little different from breast because the guideline is stratified into two biopsy specimen and for surgical specimen. For biopsy specimen, there is no cutoff. So any reactivity, any percentage where there is complete lateral or basolateral staining is taken into consideration. Whereas for surgical specimen, cutoff is 10%. And then, of course, equivocal cases go for in situ hybridization. So this is gastric cancer specific HER2 scoring algorithm. And for FADER trial, for uterine serous carcinoma, FADER trial scoring criteria is taken into consideration. And here again, there is inclusion of both circumferential and basolateral and lateral staining. Cutoff is much higher, 30% rather than 10%. And so based on the results of FADER trial, NCCN has recommended trastuzumab and not TDXT for HER2 expressing score 3 positive endometrial carcinoma. And so there are these various destiny trials, and gastric cancer IHC HER2 scoring was utilized in pan-tumor study because of the range of tumor types which were included and to account for any resulting heterogeneity of staining. And this is an interesting study. And here, tumors from pan-tumor study, all the samples were rescored using breast scoring algorithm, gastric scoring algorithm, and endometrial scoring algorithm. And it was shown that as far as breast and gastric HER2 scoring algorithm were concerned, IC 3+ showed good concordance, but 1+ and 2+, there was low concordance. And gastric and endometrial scoring guidelines, there was low concordance across all levels. And needless to say, there was a huge inter-observer variability, as also pointed out by the previous speaker. Now, coming to concordance between breast and gastric cancer scoring criteria for gynec tumors, and in this case, this study is about uterine carcinosarcoma. Again, there is only 70% concordance when breast cancer guideline and gastric cancer guidelines were used. And there was, of course, HER2 intratumoral heterogeneity, which is a known problem. And most discordant results were due to lateral, basolateral membrane staining pattern. And so naturally, if you apply breast cancer criteria, which takes into consideration complete membrane staining, then you're bound to get discordant results. And this is the explanation for difference between breast and gastric cancer HER2 scoring guideline. If you go to breast cancer, IHC 3+ is circumferential membrane intense staining more than 10%. Whereas for gastric cancer, the criteria is strong, complete, basolateral or lateral in more than or equal to 10%. And so applying breast cancer scoring criteria, which requires complete membrane staining, would lead to, especially when you're evaluating for TDXT treatment, that would lead to high false negative rate for HER2 status. And using the gastric cancer specific HER2 scoring algorithm is recommended to identify eligible patients. So the NCCN recommends to use TDXT for HER2 positive tumors, 3+ or 2+ in ovarian endometrial cancers based on Destiny Pan Tumor 02 trial, which uses gastric cancer specific HER2 scoring criteria. And this is an interesting study where recently published, more than 65,000 solid tumors were tested. And you can, and in this particular study, Ventana 4B5 antibody was used. And here for scoring, breast cancer was scored as per breast cancer scoring guideline, and all other cancers were scored as per gastric scoring criteria. And you can see almost 13.6 uterine serous carcinoma showed score 3 IHC, 4.8% of cervical cancer, and 3% of ovarian cancer, and even uterine endometrioid carcinoma also showed almost 2.7%. And coming to vulvar squamous carcinoma, 1% of vulvar showed score 3 reactivity. So summarizing, every solid tumor patient should be tested for HER2 with IHC, pathologists should score HER2 using gastric cancer scoring guidelines for all solid tumors beyond breast cancer. So there has to be awareness among medical oncologists and pathologists, and that is a critical factor. And that would lead to successful identification of patients for TDXT treatment. Thank you very much for patient hearing.
Thank you, Sangeeta ma'am. With your permission, I would like to ask quickly 2 or 3 questions that I could see in the chat.
Sure.
Is archival tissue okay to do MMR and HER2?
Of course. Archival tissue is fine, and only thing it shouldn't be very old, old archival blocks.
Yeah.
That much, and another usual fixation criteria they need to be adhered to.
Sure, ma'am. What is the preferred method of MSI testing? Is it IHC or is it NGS?
Well, immunohistochemistry is much more ubiquitous, and so we can go ahead with the, and in the cost difference is also there. So MSI, even for colorectal, in fact, more than NGS, there are other molecular methods for MSI, but we go for immunohistochemistry.
Sure, ma'am. Dr. Anna can also give her feedback on these 2 questions now, because there was a discussion on the TAP scoring and the CPS scoring, Sangeeta ma'am. So if PDL1 TAP scoring is not available, then can we consider PDL1 scoring by any other method?
I don't think I get the question. Could you repeat it?
Yeah, if TAP scoring is not available for PDL1,
Okay.
we consider scoring it by any other method.
Okay, very good. Understood. I must say that currently PDL1 status is not driven the indication of immunotherapy in endometrial cancer. I mean, CPS or TAP is an additional biomarker, but the approval of immunotherapy in endometrial cancer is not driven by the PD-L1 status. So, if you want to have the PD-L1 status because you want to know more about, their tumor that your patient are suffering, it's okay, but you shouldn't, establish your therapeutic indication based on CPS or TAP of IC.
Sure. And the last question is, how frequently you consider doing NRCA testing in endometrial cancer?
In endometrial cancer, we test at the time of the newly diagnosis. Dr. Desai can confirm because the biopsy, the analytical procedure at the biopsy much better at the time of surgery. And then we carry out all the molecular tests available in our site, that is poly, mismatch repair status, P53 status, P50, and ER and PR. This is our, common panel for all of our patients. We don't know, we carry out any additional tests.
Sure.
I
Thank you.
agree with you, Dr. Anna.
So next, we move to a case-based panel discussion focused on ovarian cancer, moderated by Dr. Pinaki Mahato, a leading medical oncologist and consultant at HCG Cancer Center, Vadodara. Joining him on the panel are distinguished experts, Dr. Sangeeta Desai from Mumbai, Dr. Sneha Rajgopal from Tata Memorial Hospital, Mumbai, Dr. Anbarsan Sekar from Actrec, Mumbai, Dr. M.V. Chandrakant from Narayana Super Speciality Hospital, Kolkata, and Dr. Mansi Shah from HCG Cancer Center, Ahmedabad. I request Dr. Pinaki, sir, to begin with his presentation.
Yeah, good evening. So, am I audible?
Yes, sir.
Am I audible? Yeah. So somebody
Yes.
can share my slides. I don't have the slides. Can somebody share them?
Yeah.
So I think it was nice listening to Dr. Oaknin and the previous speakers, and I think we are running late for almost half an hour. So I have been given a case, and based on the case, we will have some theoretical discussions as to how our clinical practice is and how it has changed over a period of time. So this is about HER2 receptor positive ovarian cancer. So I must admit my own experience in this regard has been very limited, because usually when we talk about ovarian cancer or advanced ovarian cancer, generally HER2 testing does not come to our mind. But there are certain reasons and certain situations where I think this testing must be done, and probably we'll see some tangible evidence that tells us that we have to treat these patients separately. Can you change the slide? Slide. So again, this is a hypothetical case. We have a 67-year-old Caucasian lady who has presented with abdominal swelling and bloating. She has a prior history of endometriosis, has previously underwent an abdominal hysterectomy, bilateral salpingo-oophorectomy 1 year back. She had symptomatic fibroids and she had elevated CA-125. Now she has come after 1 year of this with abdominal swelling and bloating. Next slide. Next. Yeah, so she had gross ascites, so 3 liters of ascitic fluid was tapped, and an ascitic fluid cytology was done, which basically showed that there was an adenocarcinoma of unknown origin, and with suspicion of a gynecological origin, a diagnostic laparoscopy was also performed, and I think they did a IHC as well. They looked at it and they found that it was a clear cell carcinoma of Mullerian origin, and this was a stage 3C disease, stage laparoscopically as well. Next. So my first question is to the surgeon. So in a stage 3C ovarian carcinoma, how do you decide whether this patient, if this patient has come to you primarily, whether this patient will undergo a primary cytoreductive surgery plus minus a HIPEC, or this patient should be going for a neoadjuvant chemotherapy?
Yeah, hi. Hi, good evening. So the factors I would take into consideration are basically the disease-related factors, the patient-related factors, and the surgeon and the center-related factors. If I can achieve R0 resection with respect to disease, yes. If the patient is fit enough to go through such a long surgery, major surgery, yes. And if I am very confident that I can do this and my hospital has the post-operative care to provide for this patient, then also yes.
Yeah, what about anatomy? Hello?
Yeah.
Yeah. Please continue.
So what patient factors or imaging findings influence the decision, right?
Yeah.
So usually we do look at CT scan to see if there are some important signs which contribute to inoperability, like route of mesentery involvement, porta hepatis involvement, peritoneal carcinomatosis. All this would favor, or extra abdominal disease, extensive extra abdominal disease, other than small lymph nodes here and there. So all this would influence my decision against a primary cytoreductive surgery. Likewise, if the patient has a very poor general condition, ECOG 0-3 with low albumin and lot of medical comorbidities, then also my decision would be against a primary cytoreductive surgery.
Does the CA-125 play a role in deciding?
Not always CA-125 levels are associated with the tumor bulk or the tumor burden that is there. Maybe very high CA-125 levels sometimes are associated with increased tumor burden, but we have done primary CRS even with high CA-125 if the disease is resectable, yeah.
And you don't go for HIPEC primary CRS?
No, we don't. The evidence right now is not favoring HIPEC in primary CRS.
Great to hear the surgeon saying that. Okay. So, Dr. Mansi, I can see you. So, when you have a clear cell carcinoma of the ovary, when you see a patient of clear cell carcinoma of the ovary, what do you expect? What is going to be different when you compare it with the bread and butter that we see high-grade serous carcinomas of ovary? How do you think they are different?
So for advanced disease like stage 3C disease, prognosis-wise, I think clear cell carcinomas are worse than high-grade serous carcinomas. Also in terms of the response rates to platinum and taxane-based therapy are conventionally supposed to be slightly lower than the high-grade serous carcinomas. In terms of the HRD status and the germline mutational status, again, probably a lower chance of seeing positivity. So these are probably the main findings.
Okay. Dr. Chandrakant, are you there?
Yeah, sir. Please tell me.
Yeah, so anything you want to add to the clinical presentation? These patients probably have some different clinical presentation.
I was just trying to understand, how did you know it is from ovary? Why not it is from uterus?
So I am reading the slides. I think they have concluded that is ovary. So we are just taking this discussion as if it's a case of
Right,
carcinoma.
because you operated, now there is ascites. How do you know it is ovary? So that's what I was trying to. It's
Yeah,
Mullerian,
I agree.
right?
Right. Yeah.
That's the only thing what I want to add.
Yeah. So anything more you want to add in clear cell carcinoma of the ovary?
It's fine. Clear cell carcinoma is immunosensitive. That's what I know. Otherwise, it's fine.
Okay. It is immunosensitive. Okay. Okay. So generally,
just a small addition from my side. If it is a clear cell carcinoma, then my threshold for surgery lowers, in the sense I might do surgery. Because
why
I
is
know
that?
that it might not benefit, it might
Right,
not.
because chemo doesn't work. She
well
wants to
with
operate and
chemotherapy.
remove.
Okay.
Yeah, so I
So
want.
you would prefer to go for a primary surgery if it's a clear cell pathology?
Yes, if operable, yes, definitely. Even
Okay.
I would.
Okay.
Yeah.
Okay. Next slide. Again, this is something that was presented this year in ASCO. This is about radical upfront surgical therapy in advanced ovarian cancer, the TRUST trial. Next slide. So this was about patients who had stage 3B, 3C, and stage 4A, 4B who were randomized to either undergo a primary cytoreductive surgery versus a neoadjuvant chemotherapy followed by an interval cytoreductive surgery. They looked at the OS as the primary endpoint and PFS as the secondary endpoint. Next. They also had bevacizumab in this trial. So actually, what happened in this trial, the OS advantage was not there, but there was some improvement in the PFS. Also, I think this trial was done in multiple European centers where they had gynecologists. So I think the standard of surgery was good, and therefore the post perioperative complications were quite less. The post-operative morbidity and mortalities were quite low. So that again reinforces the belief that you do the surgeries at a center which is well experienced, high volume center. Probably the outcomes are going to be good, and still we are not saying that this is the way that we should go for a primary versus interval. The jury, I think, is still out. That probably primary cytoreductive surgery, it reduces the bulk of the disease, making it more sensitive to chemotherapy. Whereas in interval cytoreductive surgery, it gives us a chance to do a surgery later. But we don't know why the OS is not improving despite having more response rates and PCR rates with the interval surgery. Probably when you're exposing the patient to chemotherapy, you're also inducing some degree of platinum resistance. And that's why probably when these patients, even though they undergo interval surgery, they get more R0 resections. There is no improvement in the overall survival when you compare it to the primary cytoreductive surgery. Next slide. So I think genetic aberrations, that means I think the HRR was tested, the somatic HRR was negative. HRD has not been mentioned. I think HRD, all of us would agree that in this patient, in any advanced ovarian cancer patient, we would do HRD if it's an ovarian primary. HER2 was done here. It was 3+. CA125 was not very elevated, 349. So again, HER2, each and every patient of ovarian cancer. Is Dr. Shekhar here?
Yes, sir. I'm here.
Yeah. So where would you do HER2 testing? Do you do it in all patients of ovarian cancer, or some particular people you would be interested in checking the HER2 levels?
So, sir, primarily, one thing I would like to highlight over here is we always do ascetic tapping and then do the cytology. But day by day, the molecular testing importance is significantly increasing. So, primarily, if the patient is feasible, try to get a momental biopsy or proper biopsy so that adequate molecular testing will be done subsequently. That is the first point. Currently, the role of HER2 testing in a first line is not available. But in Tata Hospital, we are running a trial, pharma sponsored trial, where upfront HER2 testing and directing to HER2 directed therapy trial is about to begin. So that is as a part of study we are doing, but not in general for all patients.
Okay. And where do you expect HER2 to be positive? In which kind of ovarian cancer patients do you expect HER2 to be positive?
Sir, by and large, we are not using the HER2 testing for all our patients. So I'm not able to comment about that particularly. But what I have seen in a recurrent setting in few of the ovarian cancer patients, with patients with liver metastasis, they are having a higher expression of HER2. That is not like HER2 3 plus, at least 2 plus they are having. When the patient is having pleural effusion during the time of recurrence, those patients also have seen the patient is having HER2 expression more commonly. One more thing I would like to add over the molecular testing over here is, if the patient is having endometrioid type of ovarian cancer, you can also consider MSI testing. But the endometrioid variant is very lesser. You can still consider for MSI testing, which is recommended by ESMO.
Okay. So what I read in the literature was that if you have a mucinous ovarian cancer or you have a clear cell ovarian cancer, these are the ovarian pathologies where you might have more chances of having a HER2 positive expression. Whereas in a high grade serous ovarian cancers or in endometrioid ovarian cancers, the HER2 expression is not very high. So that is what I read from the literature. Any role of NGS? Does NGS help? Dr. Chandrakant, are you fond of doing NGS in this setting?
Well, in a low grade serous ovary, yes.
Okay.
But in a high grade, I'm not sure how much.
In a clear cell carcinoma?
Not sure.
Okay.
May not do it.
So
in
I think
clear cell sarcoma, we can consider NGS testing, because when the
Okay.
subset analysis done for Nivo EP, what they found out is if the patient is having mutation in the pathway of PIK3 AKT, in those pathway mutation, they tend to respond much better compared to those patients who are not having mutation in this pathway. So this will be helpful. And they have taken cohort of both ovarian cancer as well as endometrial cancer. So both ovarian clear cell as well as endometrial clear cell you can consider for this testing.
So clear cell carcinomas, they have got more of ARID1 mutations, and those mutations are more likely to lead to platinum resistance. Also, as you said, the PIK3 mTOR pathway is also affected
Protein
in these
phosphatase
patients.
also.
So we might use these drugs in the later on setting. Yeah, next slide. I think this was discussed by Dr. Desai. So next slide. So I think we have discussed this. Is there any sorry, HER2 positivity in ovarian cancer patients? We see the tune of, as madam has already described, 5 to 10%, but probably we'll start looking at even IHC 2 plus in the future, because we saw that there is some data to use these drugs in that setting as well. Next. Again, I think this was discussed. This was a real world experience in tumor testing in 65,000 solid tumors, where it was seen that some tumors do have HER2 expression, some tumors don't, but the overall positivity is only 3%. Next. And ovary is one of those tumors where the expression is slightly on the lower side when you talk about the IHC 3 plus and IHC 2 plus. So I think it is around 10 to 15%. Next. Next. And NCCN basically recommends the testing, as you said, in the recurrent ovarian cancer, because now we have got some data of using this TDXT that was discussed. So in the recurrent ovarian cancer, yes, HER2 testing should be done. Next. Yeah, next. Next slide. So again, this was very interesting and eye-opening, that we need to look at the scoring criteria. So as was very well discussed by Dr. Desai, that you have got more basolateral and lateral staining in the gynec cancers as compared to the breast cancer and gastric cancer, and especially the concordance between gastric and endometrial cancer or other gynec cancers is not very great, especially when you've got the low HER2 expression. So it is important to talk to our pathologists as to what they are doing when they are reporting a HER2 in these kind of cancers. And I think CAP will come up with some guidelines that will tell us how to label these HER2 testing in these patients, especially when we are looking at IHC 2 plus or IHC 1 plus. Next. So this patient actually received neoadjuvant chemotherapy. Somehow, I think they felt that this patient was not a good candidate for primary cytoreductive surgery. She received neoadjuvant chemotherapy with carboplatin paclitaxel for 3 cycles. There was not much response. The CA125 actually went up. This patient then underwent a surgery. The CRS was actually R0 resection was there. So again, Dr. Sekhar, if this kind of patient is there, you have treated with the neoadjuvant chemotherapy, the patient has not responded, what will you think? Will you change the therapy, or what will you think in this patient in the adjuvant setting?
Sir, first thing I would like to confirm the diagnosis, because most of the time high-grade serous carcinoma patient respond well to platinum-based
So this
therapy.
is a clear cell
So,
carcinoma. As Dr. Mansi said, that
uh,
probably they don't do well on this treatment.
okay, sir. If it is a clear cell histology, then it will be expected in most of the scenario. Likely surgery and then adjuvant chemotherapy, I'll continue with the same, sir.
Okay.
If a
Dr.
patient
Yeah.
is other option is we can consider HER2 testing also. There is a
Okay.
small retrospective data for HER2 testing. The if you see HER2 3 plus, which is higher in the mucinous variant, but if you see HER2 2 plus and 3 plus, it is higher in the clear cell compared to the mucinous. One good thing with respect to clear cell carcinoma variant is even in 2 plus, the TDXD has very good response rate, even in 2 plus variant also. So that is one option we can consider if the patient affordability is there. Second option is there is an option of doublet immunotherapy, like Nivo IP combination is also there. If the patient is affordable, then that option also comes into picture.
Okay. Okay. So Dr. Chandrakant, your views on immunotherapy?
I agree, like I'm not sure when there is no disease at all, whether to give or not. If there is gross disease, yes, immunotherapy is an option in clear cell carcinoma. And in chemo, there are some anecdotal evidences of irinotecan doing better in this subset.
Okay. 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 Next slide. So actually, this patient went on maintenance pembrolizumab, and there was some peritumoral CD4, CD8 plus cell infiltration that was seen. So it was decided to give maintenance pembrolizumab. However, didn't respond. There was rapid enlargement, new abdominal lymphadenopathy. Then this patient received bevacizumab. The CA125 kept on rising, and then the patient actually received oral cyclophosphamide. So some kind of triplet regime. Again, Dr. Mansi, what are your thoughts on this durvalumab that you have used in ovarian cancer? Any you have used in this setting, ovarian cancer?
No, so I've not actually used durvalumab in ovarian
Okay.
cancer. I've really not had
Okay.
any good patients that
Okay. Okay.
fit the bill.
Okay. 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 We'll not discuss them. Next slide. So then this patient, because this patient had a HER2 3 plus at baseline, this patient was started on deruxtecan. And after 3 cycles of deruxtecan, there was a significant response with a 50% decrease in the CA125 as well. Next. Any other alternatives Dr. Mansi would have considered in this patient?
Since this patient had a HER2 3 plus by IHC,
Yeah.
I think trastuzumab deruxtecan would have been the preferred treatment option.
Okay.
Not in the adjuvant setting, but I think once the patient had obvious disease, measurable disease.
Does anybody want to add here something? Doing any other molecular testing? I think we have already discussed this. Retesting for markers in case of disease progression.
What
Yes,
about
if baseline.
trastuzumab? Trastuzumab
Yeah.
won't work in this.
So, do we have data for trastuzumab in ovarian cancer?
In high-grade serous endometrium, yes.
In endometrial cancer, we have, sir, unfortunately, ovary, not much.
Ovary, I am not sure. Endometrium, yes, I agree. We have data, some very limited data, but we have data.
Endometrium, we have data, sir. We can give as a first line also as a combination, but not in ovary. We don't have it.
Next slide. So I think this was already discussed, the Destiny pan tumor 2. And what was basically the thing is that there is response, especially in the IHC 3 plus and to a lesser extent in the IHC 2 plus, not in IHC 1 plus. And we need to look at how the HER2 expression has been tested. So they have used the gastric cap, but probably we'll have newer guidelines telling us how to do this separately because the concordance is lower in the IHC 2 plus and IHC 1 plus. Okay, we can go ahead.
Sir, but NCCN recommends for 2 plus also in ovarian cancer. In endometrial cancer, it is only for 3 plus.
Okay.
There is a small difference in there in ovarian endometrial cancer.
Okay. Okay. Next. Next. So we can see here that in the IHC 3+ subset, there was an improvement in the PFS and the OS, but not in the IHC 2+, that the significance, it is not that significant. So maybe in the 3+, I think we have more confidence to use this therapy. Next. Again, I think the same thing has been shown here. There is a good disease control rate at 12 weeks, and the overall response rates are also good in terms of partial responses and stable disease in many of these patients. Next. Again, the same thing that in 3+, I think the response is better. Next. And prior therapy is probably, it's not going to influence much. Probably if we have used some other drugs, probably the response is going to be there. Next. Again, biomarkers telling us whether it should be used or not. We are not sure about this. Again, I think we should use this irrespective of some other biomarkers. Next. I think we have discussed this. Next. Does anybody does reflex fish if the HER2 IHC is 2+? Dr. Sekar?
Yes, sir. We were doing, even though there is not much data to support it, we were doing. And recently, we discussed in one of the meeting also. We can explore the option of NGS also in this situation. How far NGS will correlate with the HER2 testing, because that will also be one of the important factor.
HER2 by NGS, are you saying?
HER2 by NGS. We can explore the option. We can see for the copy number amplification or variation, and then we can correlate with that.
Okay, got it. Next. So again, which patient subgroups would benefit the most? Dr. Mansi, you can take this question.
So talking about, I think, ovarian cancer, right?
Ovary, yeah.
In
It's
ovary.
in ovary.
In ovary. So in terms of ovary, I think irrespective of the histology or whatever other markers we use, if the tumors are HER2 3+, especially in the recurrent setting, we can use it in any line. First line, second line, whatever. In terms of the HER2 2+ setting, the overall response rates are in the order of 25 to 30%. Now, if we are looking at, so in the ovary setting, if I'm looking at first line recurrence for HER2 2+, I probably would not put it up there because we have better agents that we can use. However, in the platinum refractory setting, because we don't have a lot of drugs available in India right now, HER2 2+ or 3+, I think I would use HER2 and hope for a response, because platinum resistant setting chemotherapy responses are not so good. So if the patient responds, I think, less toxicity and
So in the
probably
platinum
better.
resistant category, are you more interested to use this?
Yeah, because platinum sensitive, I probably would use platinum.
Yeah, platinum. Yeah. Next. Okay, next. So I think this is the last slide. So I think HER2, we need to decide which all patients probably won't have this, but patients who have mucinous and clear cell variant, they are more likely to have this. You have different kind of genetic mutations. The BRCA expression, the P53 expression is lesser in these patients. These patients are more likely to be platinum resistant. So we should be prepared to change our therapy as per our NGS or whatever we are doing, and we need to not miss the HER2 expression. And in these patients, probably, as Dr. Sekar said, that there is a good response. Even in the IHC 2+, you might get good response with deruxtecan. So I think now with widespread use of deruxtecan, we have got the confidence, the toxicities we are able to manage, and we are understanding the drug in a better way. So probably in this subset of ovarian cancer patients, where especially we don't have many therapies, once a patient becomes platinum resistant, it is very difficult to treat those patients. We have a new exciting new option that probably we will be able to use now. I think that's all from my side. Thanks to all the panelists for the active discussion. Thank you.
Thank you. Thank you, Dr. Pinaki.
Thank you.
If Dr. Anna is here, ma'am, any expert
I have
comment on
one
this?
question to Dr.
Yeah.
Anna. So is there any
Happy
role for
to
ctDNA in
respond.
ovarian cancer or endometrial cancer? So
Yeah.
is there any role for ctDNA testing in endometrial cancer, or ovarian cancer, because we come across this part frequently in other cancers, but unfortunately we don't do liquid biopsy. And even when the patient recurrent ovarian cancer setting, it is difficult to obtain biopsy in those population. So what is your
Yeah.
opinion regarding ctDNA testing?
Yeah, I mean, thank you for your question. I mean, your question is really interesting, but the short answer is unfortunately, we have not validated yet in a prospective way the role of ctDNA to identify early recurrence in ovarian or endometrial cancer and to, to implement any therapeutic action based on that. At my institution, we are carrying out this kind of analysis in patients with ovarian cancer who are receiving PAR inhibitor as maintenance. We are trying to correlate the ctDNA at different time point with the C125 and CT scan, and we want to determine if using ctDNA we will be able to detect an early recurrence. If detecting this early recurrence and implementing new line of therapy, the patient will have a better overall survival. But up to date, ctDNA is still a matter of clinical research. It's not established in the daily practice.
Sure, ma'am. And there was one discussion that came out, role of trastuzumab versus the role of TDXT in ovarian cancer. Do you have any comments on the same? Because we don't see the data for the same, but would you like to comment?
I mean, the data from TDXD in ovarian cancer, I mean, are really, really compelling. The population that we enroll in the Destiny Pan Tumor 02 were a heavily pretreated population. The majority of them have already received three lines of chemotherapy, and we enroll all different kind of histologies. So I think, when the patient relapse and the patient is not suitable for further platinum therapy, I mean, TSD is an excellent therapeutic option as long as the patient's tumor express HER2 2 plus or 3 plus. Currently, I mean, as you are aware, we are running the part 2 for the Destiny Pan Tumor 02, and we are analyzing different cohorts, namely those patients whose tumors are 2 plus each positive, 1 plus only, and for sure 3 plus we are trying to reconfirm. But importantly, we are trying to figure out in those patients whose tumor are not really high expressed, we can also observe responses for this patient with ovarian. So I think TDXD is an excellent option. Unfortunately, in Europe, we don't have the agnostic approval, but, despite not having this approval, we are testing all of our patients in order, to be able to enroll in any trial that that is having TDXD as an investigational drug.
Sure, ma'am. Thank you. Thank you so much. So now we'll move on to the next topic, that is endometrial cancer. I think Smruti ma'am has some point to raise.
Yeah, I just wanted to know again. Good evening, Dr. Anna Oaknin. That was a wonderful talk. I want to know that, patients who have received trastuzumab in the first setting and you were to repeat the HER2 and there is a loss of HER2 as you also see in breast cancer, then what is your experience about treating these patients with TDXT?
This is a very good question, and I would like to have the right answer, but unfortunately, I don't have. I mean, our experience with TDSD is based only on the Destiny Pan Tumor 02 because, I mean, the drug is not approved in Europe. And then when we enroll patients in this trial, the tumor specimen where we determine HER2, should be, I mean, not older than 3 years. So, I mean, patients whose tumor are, older, or those patients who have a newly diagnosed and then recurrence, we don't have the determination in the per biopsy. So, to your point, the key question in ovarian cancer is if there's a change in the HER2 expression over the patient's journey. It will be ideal, to have this information mainly due to the heterogeneity of the gynecological tumor. But currently, I must say that to the best of my knowledge, these data are very poor. In gynae, we are trying to generate this data from the Destiny Pan Tumor 02, and I hopefully that surely you will have a publication out where we address these points. So, I mean, what is the correlation between biopsy and an excisional tumor specimen? What is the correlation between newly diagnosis and recurrence? Because honestly, we need to polish all this data in order not to miss any patient who may be candidate to receive TDXD.
Yeah, thank you very much.
No, thank you for your question.
Yeah. So I think now we move on to the next panel discussion. Can I load my slides, please? Can I share my slides?
Yes, ma'am.
Yeah. Can you see my slides?
Yes, ma'am.
Yeah, so we're going to have a case discussion very quickly on HER2 positive endometrial cancer. And I would like to call on my panelists, Dr. Shona Nog, Dr. Vaibhav Chaudhary, Dr. Rohit Ranade, and Dr. Vijay Agarwal. Just want to know whether all of you are there. Anybody missing? So I think we can proceed. So quickly, to save time, we have a 56-year-old patient who presented with postmenopausal bleeding, abdominal distension, and she has comorbidities with type 2 diabetes and hypertension. Father had colon cancer, so that is important. So what is the diagnostic workup would you do for this patient? So can I begin with Dr. Shona Nag, please? Dr. Shona Nag, is she there?
Hello, ma'am. We have Dr. Rohit Ranade, Dr. Saurav Kumar Mishra, and Dr. Vijay Agarwal on the panel.
Okay. So can I ask Dr. Vaibhav Chaudhary? Is he there?
No, ma'am,
These are
sir
the
is
names.
not joined.
So Rohit Ranade, Vijay Agarwal,
and Saurav Kumar Mishra, sir.
Okay. So Dr. Rohit Ranade, can you tell me?
Yeah. So good evening all, and thank you for the question, madam. Am I audible?
Yes, sir.
Yes.
Hello.
Yes.
Yeah. So in a situation, the first test that we would do a hysteroscopy guided endometrial biopsy in any lady who has a postmenopausal bleeding. Most of the patients will if ultrasound is not done, we would first do an ultrasound, but most of the times patients do get referred to us where an ultrasound is already done. So in a situation where an ultrasound is not done, we would do an ultrasound, and depending on the endometrial thickness, we would do a biopsy, which would be a hysteroscopy guided endometrial biopsy. And depending on the report, then we would decide what would be the further imaging.
Okay. So this was the gynecological examination which showed an enlarged cervix and uterus 6 to 7 centimeters, parametrial involvement, but not up to the pelvic wall. And then, of course, there was vaginal involvement as well.
Yeah.
So this was what it was. So what are the biomarkers that you would like to order and the method preferred, whether IHC or NGS? So can I ask Dr. Vijay Agarwal?
Yes, hi, madam.
Yeah.
So I think if the biopsy has proven this to be an adenocarcinoma of endometrium, I think the common biomarker testing that we do is for MMR proficiency or deficiency, maybe a HER2 and a P53.
Okay.
I generally prefer IHC because that's easier, it's easily available in an institute, and all the three of these MMR, HER2, and P53 can be done through IHC. So it's quick, easy, and cheap, and that's what I tend to do upfront.
Okay, that's good. What about NGS? So anyone would like to comment on that, Dr. Ranade or Dr. Vijay?
Yes. So as a routine for all endometrial cancers in our institute, we do whatever Dr. Agarwal has said. We do MMR, P53 and pole on NGS. As of now, we are not doing routinely on IHC. Primarily, it is because of the financial reason, because primarily for pole you need NGS. And only pole is not available in the outside laboratory.
Exactly. Yeah. So now moving on, the pathology showed a poorly differentiated high.
Yeah, in addition to, sorry, I'm so sorry to interrupt you. In addition to this, we also do ERPR and not HER2 in all cases, but in all cases we do at least ERPR, we do in all cases of endometrial cancer.
So where do you do the HER2 testing? Because it's the main topic in the discussion.
Yeah, so I mean, HER2 is only done in, as of now, is only done in recurrent setting in our institute, not in upfront setting.
Yeah, both those with P53 mutation or, high grade serous carcinosarcomas.
No, there also we are not doing HER2 testing as of now.
Anybody else would like to comment?
Can I comment, Dr. Vijay, here? I
Yes.
think I have a clear distinction on the kind of testing we do, whether we're dealing with early endometrial cancer or stage 3-4 metastatic cancer. Now, if
Of course, this is an advanced case.
Yeah, in an advanced case, upfront, all my patients would get a HER2, would get an MMR, and would get a P53. I don't do Pole for advanced.
Okay. So, yeah. So then this is to do, and this is the CA125. And of course, we do a hereditary germline because the father had colon cancer and she has endometrial. So we would do the germline, which was negative. So this is just to show, this slide has been seen previously, that what's the incidence of HER2 positivity in these patients. So again, this slide has been shown. So for want of time, let's move on. So we know we are mainly dealing with the endometrial, and we know from the previous speakers, the testing and also what is approved of in the first and the subsequent line therapy. So what is the next line of investigation? Which histologic subtype do you mostly see HER2 positivity? Since it has been addressed before, quickly, Dr. Rohit Ranade.
I'm sorry, I have not, I missed the previous talk, so I'm not aware which.
No, so what is the next, which histologic subtype do you mostly see HER2 positivity? Or Dr. Vijay Agarwal?
Yeah, mainly in serous. It's more commonly seen in serous, probably co-mutation with P53. So the aggressive types are the ones that we see HER2 positivity up to 30%. In the endometrioid, not so much. Generally, if you have a non-endometrioid is when we look for a HER2 in those.
Yeah, and also in carcinosarcomas.
Carcinosarcomas.
Yeah. So I think that's important. Then, this is the pelvic MRI, which shows the tumor mass and the extension and also that peritoneal metastasis. So it's a stage 4 HER2 serous endometrial carcinoma, which is HER2 positive. So now, again, the scoring criteria has been dealt with very well by Dr. Sangeeta. So I would want to know that which one do you use in endometrial cancer? So I think all of you would be able to reply to that. Dr. Vijay Agarwal?
It's the gastric cancer scoring as well.
Yeah. So apart from breast, all the other solid tumors, you use the gastric cancer. And would it be helpful to incorporate this scoring criteria used in the report? Is it usually done in your institute?
It's not because it's presumed, but I think it will help if it's there.
Yeah. So the next question is it important to standardize the HER2 testing across all tumor types? And I think this question, Dr. Saurabh Mishra, what do you have to say? Dr. Saurabh Mishra, are you there? Or Dr. Vijay Agarwal?
I think it's very important that we standardize it. I think subconsciously, I think it is already done because you have the breast cancer for the breast and everything else for the stomach, for the gastric scoring. But whether individually we do separate scoring for endometrial, I don't know. That's the answer. I think will have to be led by what the CAP guidelines state. But
Yeah.
currently in our practice, we do the gastric cancer score, gastric HER2 scoring system for the non-breast
Yeah.
ones.
Yeah, and that's
I
because of
think
the
what
heterogeneity,
hmm.
and this has already been dealt with. So let's move on to the next because we are already running short of time. So this is the HER2 scoring system in gastric cancer, and Dr. Sangeeta had already alluded to this. So now coming to the case, patient underwent a cytoreductive surgery followed by carboplatin paclitaxel with 6 cycles of trastuzumab with chemotherapy 6 cycles and trastuzumab totally 9 cycles. But after 5 months of maintenance therapy, the imaging again showed progressive peritoneal metastasis. So I would like to know from Dr. Ranade that what is the next line of treatment would you give to this patient, and any role of immunotherapy because the patient is proficient MMR. So Dr.
Yeah,
Rohit
so
Ranade? Yeah.
so that would depend. The imaging has revealed a progressive peritoneal metastasis. If the performance status is okay, and so there is some role of giving durvalumab as per the data from the DOE study, because that's the only immunotherapy that can work in pMMR as compared to the other immunotherapies which work mainly in MMR deficient population.
Okay. So what about Dr. Vijay Agarwal?
Yeah, I mean, in this situation, I think I would I would kind of look at Enhertu TDXT as an option rather than immunotherapy,
Yes.
because the data from the Destiny Pan tumor is actually quite good.
Yeah. So Dr. Saurabh, do you agree with this? Whom do you agree with? Dr. Saurabh, is he there?
I don't.
Okay. So, definitely because the patient is HER2 positive, you would prefer to use TDXD in this situation over immunotherapy. Although Dr. Anna Oaknin also actually mentioned about the study which is in progress where they would think about how immunotherapy would act in this patient population. But for the time being, you would use TDXT rather than immunotherapy in these patients. And we don't have the data of combining the two. So, would you have considered any alternative first line management in this case? So, Dr. Rohit Ranade?
Sorry, I don't have much experience in this setting, so I would
Okay.
let Dr. Vijay
Dr.
answer
Vijay
this.
Agarwal?
Yeah,
What
no,
would you?
I think this is the standard. The GOG study looked at
Yeah.
combining trastuzumab with carbopacli with a decent improvement in PFS. So I think whatever the first line was given was pretty standard. I don't think so. This current data for TDXT in first line.
Yes.
So I think apart from minor nitpicking of whether we wanted to give anthracyclines or taxanes, but essentially I don't think sort of changed much from the first line treatment.
Okay. And
The
how?
only
Yeah.
Can I just ask? The only thing is, I was a little surprised why they went for a upfront cytoreductive surgery with so much disease.
So a lot
With so
of
much
a
disease, it's
lot
a
of the
little difficult.
She
Yes.
had a lot of bleeding. I mean,
Okay.
so that that might have been one of the reasons. But
Hmm.
correct, you made a point there. But
a lot of the
that might have
surgeons,
been.
a lot of the surgeons, if there's serous for ovarian and for endometrium, unlike cervix, they tend to go
Hmm.
for upfront surgery for symptomatic relief, local control, and things like that.
So, how often do you retest for HER2 and other molecular markers in case of disease progression? So I think I had asked one question related to HER2 and that was answered. But just to know from the other panelists that do you ask for a repeat NGS in these patients, or do you look at the MSI, which was, say, high initially, suppose it was high, and now if it is, would you repeat MSI status also? So Dr. Vijay Agarwal, Dr. Rohit Ranade.
So I don't
No.
repeat MSI
No.
status, but I would be tempted to repeat the HER2 expression. Because you can lose HER2 expression over time, particularly when you've given anti-HER2 treatment, like we see in the breast. Whether that will impair my decision to give Enhertu, I am uncertain about that.
Yeah.
But for microsatellite instability, I wouldn't. If I found a deficient MMR once, I'd probably stick with that.
Okay. Yeah, so that answers all the questions, and let me skip these slides because this was already, addressed and it was shown as well. But you can see some of the impressive results of 57.5% overall response rate and also the median duration of response not reached. So I think this is important, and this was already spoken about, that it's mainly the +3 that actually benefits, and to some extent the +2 not so well with the overall population, but where you have mix of all. So this is to do with the PFS and overall survival results. And again, by the HER2 status, as I mentioned, that +3 and +2 are the ones who benefit more than anyone else. And but as you know, for endometrial cancer, it's approved for +3. And of course, this is the overall safety summary. The discontinuation rates were, just 8.2%. So that speaks of the tolerability of this combination. So what are your impressions overall about this study? So can I ask Dr. Rohit Ranade? Dr. Rohit Ranade, are you there? Or Dr. Vijay Agarwal?
Yeah, I mean, I think it's a good study. I think it is a brave study to be done to look at different tumor types in one study. But when you look at the gynae cohort, the endometrium particularly had about 40 patients. But when you look at the central review of the HER2 testing and the responses and the PFS is actually quite good. And so I would be tempted to give it to the vast majority of the patients after failure of one line of treatment if they're HER2 positive.
Yeah, so I think the second question is answered, that HER2 testing is changing the future of is some of the subtypes of endometrial cancer, and it is one of the testing that should not be forgotten. So very important message from this. And I think this was also answered, that fish testing in HER2. Dr. Vijay Agarwal, I think now you're the only panelist left. So can I ask you again?
We are doing it. We are doing it, madam. We're looking for amplification if expression is 2+.
Yeah.
So we're asking for
No,
fish,
but
but
do you do fish if it is IHC +2?
yeah, I do them. I do them currently.
Yeah.
But that impairs my decision to give Enhertu. I'm uncertain. I'm currently not giving Enhertu to 2+ without fish.
Okay. Well, at least in the study that I just presented and was presented before, they only used IHC, and they had not done the fish testing. So again, in which line would you prefer TDXT?
Ideally, second.
Yes,
Second
as
would be.
per the data that was presented. Absolutely right. So this is about the pan tumor. And again, this was something which was presented. And as you know, bladder cancer has the highest rate of HER2 positivity. And it's around 12% in endometrial cancer. And again, if you look at this group over here, the endometrial cancer, if you see whether it's by biopsy or from the tumor specimen, there's a good deal of concordance as far as HER2 testing is concerned. So this is the take-home messages, that you must consider this testing for the solid tumors, that breast gastric scoring, except for breast gastric scoring, should be considered. And we have to be aware of the scoring criteria. And because of the standpoint of cost and all, the previous study proposes that upfront HER2 IHC testing may not be required, but for those who are rarely positive. But nowadays, with the cost coming down, I think we would do it in the setting that were described by the previous panelists as well as the present ones. And comprehensive genomic profiling could be used as a screening test, whereby HER2 IHC would be performed on tumors that are ERB2 copy number amplified or ERB2 messenger RNA gene overexpression. And this could actually optimize the laboratory workflow. And so with this, I'd like to thank the panelists. I would like to thank the organizers for giving us this opportunity to actually discuss about HER2 positive endometrial cancer. And I'd like to thank Dr. Anna Oaknin for that wonderful talk. Thank you.
Thank you. My pleasure.
Yeah, thank you. Thank you so much, everyone, for joining and giving your very valuable inputs today.
Thank you so much. Have a lovely evening.
Yeah. Thank you. Good night.